All right. So, come on. So, Canuck Place Connects, the redo. Thank you for joining me again, Camara. So, I'm Karina Chow, Associate Director for the Fraser Valley region for Canuck Place. My superpower is enthusiasm. My weakness is Black Forest cake. Oh, look at that. I think I changed it. And we're talking this morning about the Nancy Chan Enhanced Community Care Program. Big old thank you to the Chan Family Foundation for their generous support. It's my pleasure to introduce Camara Van Bremen, whose superpower is preparing Tex-Mex meals because she used to live in Texas, and her weakness are sour keys and Solly's cinnamon buns. So I'm now going to pass it off to you, Camara, and away we go.
Thank you. Thank you, everyone. I am sharing my screen now and getting my presentation up and going. So what I wanted to talk to you about today was pediatric palliative care, and really a review of the virtual care and support we give families across the entire province. And this was happening even before COVID. I don't have any disclosures, and I just wanted to let everyone know that the family that I'm speaking about today is an example of our care, have given permission to use the family, photos of their child and the family and his story. So quickly, the objectives to review our program, and many of you will be well aware of our program and services. Talk a little bit about the domains of care provided by pediatric palliative care. And again, many of you will know about this, but this is just a little bit different way to outline some of the care that we do give. And then provide a specific case and highlight ways palliative care can provide virtual care to patients, families, and other healthcare providers across the province of British Columbia. So this is a well-known map to people who have been exposed to our services. This is, of course, BC, and this is an older map of the location of families, but it's still pretty consistent about where our families are placed. And as you can see, many on the Lower Mainland and the island, but then also distributed across BC and quite far north. We have 2 hospices, one in Vancouver, started in 1995, and then in Abbotsford, 2018. We started inpatient services from there. Our care really does cover across other locations, including consultation services. A lot of them are to BC Women's and the BC Children's Hospital, but we will go to other hospitals in the Lower Mainland in person, and we provide telephone and video conferencing with colleagues and patients across the province. Really, the focus of this presentation is the home and community piece that I lead. And the bulk of the care is really provided through telephone and video support. And this is, again, to families and other healthcare providers that are involved in that family's care. And then, of course, depending on the location, we also provide home visits. The 5 things that we do for all of our patients that are on the program, to varying degrees, depending on their illness, their trajectory, what location they're in, are these 5 things. And I'm just going to briefly touch on this. Many of you know pediatric palliative care are experts in pain and symptom management. This is a really big part of our pain, or part of our service, where we help reduce suffering in children, and we help other providers know what to do for children who are suffering. Care coordination, this is looking at how do we coordinate care across locations. Often this is very much left to the parents to manage, and they need our help and others' help to get this care in a timely, well-communicated way. We do a lot of complex communication in pediatric palliative care. One of the things I like to say our team is known for is this ability to be in uncertainty. It's not black and white what families want or need. It's not black and white about what the course of the illness will be. And so we really have to talk about families' values and hopes and fears to get an understanding along with our clinical knowledge to help them make decisions. Family support. huge. We do this in all of our clinical domains and volunteer domains in terms of really meeting the family with what they need to have. And again, rec therapy, counseling, nursing, volunteers, kitchens, so many people provide this support to families. And that this goes on not only during the illness, but in bereavement. And then management of health conditions. All these kids come with diagnoses that are complicated. They may or may not be the thing that's causing them to get sicker or that will lead to their end of life, but they have lots of pediatric issues that we also have to manage. It's stuck. Let me see. There we go.
Got it?
So
Okay.
a big shout out to the Nancy Chan Foundation and for the donation the Chan family gave us to really seed fund this program. And what we call it is in the enhanced community care. And the reason we call it that is because not all children will get all the services that we provide, depending on where they are in their trajectory or what their illness is. So this diagram really tries to narrow down and really specify the kids that we actually put on this program. So it's a program within a program. So yes, we have 400 children on our program that receive all sorts of care from Canuck Place, including respite, clinical consultations, family support, and all those things. We have then sort of around 50 kids at any time where the families are needing more support. And usually these kids are in the community phoning in, asking for things like, my child's having more symptoms. What should we do? Is this a time to go to a hospital? Can I get more respite? Is there something we can tweak? And we really work with them, providing sort of extra care virtually, which families have told us over and over again. Now, these families aren't necessarily the ones that we would go to a home visit, or we would be the ones coordinating their care or doing all of that. But what happens is we're being responsive to changes the family needs. And then we sort of figure out, is this giving us messages of where the child's at and what the next steps should be? The Enhanced Community Care Program really is this smaller group, around 14 kids that we follow ongoing for a number of months. These are the kids where their trajectory is shorter. Now, of course, we never sort of know exactly, we don't have a crystal ball, we can't tell families exactly what's ahead, but given our clinical expertise and what we know about certain diseases, we have an understanding the time, maybe 2 weeks or months. The other thing that's super important about this is that the goals of care are really comfort focused, or they only want to return to hospital for reversible causes. So these might be those kids that there's no longer more cancer treatment available or a heart surgery, or every time they've gone to hospital, the child is in a worse off position because the condition continues to get worse. And so families' goals might be that they want to be at home and as comfortable as possible as much of the time. And when that happens, we really become kind of the primary team or at least a very strong collaborative partner with other providers. And we start to then really think about how often should we phone? Is this video contact, and whether we do a home visit or not? So for example, we had a family calling 3 or 4 times in the last couple of weeks, really established that this family's goals, because of where this child was in the trajectory, that they want to be at home and give comfort focused care at home. I was able to send a very skilled nurse out to their home yesterday to do an assessment and to start to do more care planning. So we're a very responsive system, which is really great. I'm going to just share a little bit about a beautiful kid named Cooper, who was born September 1st, 2008, and he died last year in May. One of the first things when we met him, he gave us his business card, which included to say that he had ninja skills, metal detection services, kitty sitting experience, and he was also a ghost seeker. Cooper was born in Powell River, and at the age of 6, he actually started having neck pain, intermittent headaches, and weakness. He was seen by his GP, who knew him very well, and he was referred then to a pediatrician and underwent a CT, where they did find a very large brain tumor. This, of course, is a very serious illness and was flown down to actual BC Children's and admitted to pediatric intensive care that very day. These are just some pictures of the extent of the disease and over time how it grew. So in 2014, he had a mass in his brain, underwent surgery and radiation, and did really quite well. Unfortunately, 2 years later, he had relapse in the spine and more radiation. In 2017, he just actually underwent a routine exam and scan, and they actually saw another relapse. So at the age of 9, there was more disease present, but he wasn't having any symptoms. And it was this time where the oncology team let us know about him, but he wasn't having any symptoms that were causing him pain. A few months later, he did find to have brain and spine more tumors and worsening pain. And this really became a point where it was important to meet our team. And we were there at the meeting when the oncologist talked about no further treatment as there was too many areas of disease. So because of his symptoms and his pain, and they live far from home, they did decide that they would be admitted to Canuck Place for a pain and symptom management stay. The family, we really got to know them. They understood that the tumor was slow growing, which meant time was uncertain. It could be weeks, months, maybe even a year. No one knew for sure. What they did know is that depending where the tumor grew, he could have more symptoms, more loss of function, more pain. The parents agreed that treatment wasn't going to likely help, and so they really wanted to focus on getting home. So when the team turned to me and said they want to go back to Powell River, that's a 9-hour, 2-ferry ride away in a small community, do you think we can do that? So the first thing that we do when we want to send a child home with these goals is we figure out a team. And what I call them is a not work team. So these are teams that really form around a specific need. They're composed of people who don't usually work together. So we have to figure out our own pacing and who's good at what and what's the role and everything. So it was really awesome. I was able to get in contact with his family provider, who actually gave birth to him and was also his parents' GP, who really felt quite comfortable with palliative care, although was very nervous about pediatric palliative care. I convinced the adult palliative care nurses to do home visits. An occupational therapist was amazing. And then we were able to get nursing support services, which is a program that is PHSA, able to provide respite in the home up to 56 hours a week if they have staffing. So we got all these people together and we had a meeting. We did a virtual meeting, Zoom meeting on the phone. And I was able actually to fly up there and meet with them as well. Care coordination, so this is a big part. Who's doing what, when, and there. And so initially we were really the ones in charge of where people were going and what that plan looked like. But over a number of months, home care nursing really started coordinating this and providing the bulk of that. We were able to be the 24-hour line contact, which is so awesome. We have a 24-hour line to pediatric experts. And we also met regularly with the community team. So myself or Nadine, a CNS at Canuck Place, did these teleconferences every 2 to 4 weeks. When we made changes to the medications or had updates, we used email or fax. This is just a quick example of one of the meetings that we had. So we talked about the last pain crisis, how he was doing in terms of his bowel movements, his stability, and what his intake was. As I said, Cooper had a lot of care changes over time. There was a lot of moving parts. And so these meetings really offered an opportunity to review symptoms, generate action items, and then also these meetings became a place where we could do some informal or formal teaching. At one of the meetings, the team actually asked, can you share with us more about parental bereavement? And so I was able to bring one of the counselors on board, and they did a session for them. Here was a monthly schedule. The parents got very frustrated and many parents get frustrated when people are asking the same questions on the same day and they're having to repeat themselves over and over again. So the nurses in the home actually set up this beautiful calendar. Every month we got this calendar, whether it was us checking in or if it was a nurse or whether there was a visit. And it really reassured all of the clinical providers as well to say, I know they're getting looked after. I don't have to phone and bother them because I know his GP will be seeing them today. And so this was really, really nice. We really did the bulk of the pain and symptom management at first, and then handing it over to the GP, other than one of the medications we had to order because she didn't have a license for it. So we really he had such complex and difficult symptoms. And I think if, we give parents bite-sized pieces about what they have to manage, because if they would have known all the things that Cooper was going to go through, it would be overwhelming. But they took each piece, learned, incorporated into their care, became experts, and were able to support him at home with the support. So he struggled with pain, nausea, agitation, panic, progressive weakness, bowel and bladder incontinence, complex wounds, and shortness of breath. He had them all. This is a little bit of an example of how we help families navigate these really complex symptoms. We'll make something we call a symptom algorithm. So we'll say things like extreme pain. Here are the 3 steps that you need to do to help your son. Or if he becomes very agitated and scared, here are the other things that we do and we support. And these get built upon and changed as he changes. As I already mentioned, complex communication, that whole idea of understanding families' values and goals, understanding the child's wishes. When he came for his first admission, we did something called the Serious Illness Conversation Guide, which is very, very helpful in understanding what parents know and what they want to hear and how far planning they can do. Cooper was very involved in decision about location of care and understood that going home meant going home and likely not coming back to hospital or to here, because he was having more difficulty moving and managing. And his whole thing was to be home with his parents. We talked to parents, we gave them some care planning about what might be ahead without really being conscious of not overwhelming them, but knowing that they always had a number to call, they knew the things to expect, and they knew what to do when those things happened. I just wanted to share that when I did an exercise with the parents and Cooper at home during a play therapy session, the parents and Cooper identified each other as their best supports. They are the 3 musketeers. That was just remarkable. They traveled so much. They had so many adventures. Cooper identified also that his comfort when big emotions arise was petting Goose, the cat, cuddling with parents, and playing games. They had a lot of games in their house. All members of his family enjoyed travel and time together. That may include the fort on the beach. They had this beautiful fort very close to their home. And then doing Lego. Even when Cooper lost the ability to use his arms, his dad would be his arms, and Cooper would instruct him how to build whatever piece they were working on. He had huge structures. And then they were all very interested in facts and reading and learning, and yeah, just so much fun to be around. Family support continued virtually as well. We had counselors that would phone in and have specific meetings. We also engaged some support locally for them. The local hospice society was able to fund a massage therapist that would go in and massage mom and dad who were very sore from all the physical care. There was lots of really amazing ways the community supported this family. Family support also includes anticipatory guidance. What does end of life look like? How do you care for the body? And how do we make memories? Not only the tangible things like maybe handprints and molds and fingerprints, but also making memories and living each day with such purpose. And this family was amazing in doing that. So over the care of over a year, actually, we had Cooper on our program, and actually they're still on our program for bereavement. He had 5 stays at Canuck Place, totaling just about 20 days. He had over 63 calls from our team to the family, and we consulted with the community providers at least 35 times. So this was all done virtually, which is really amazing when you think about the effectiveness of the care, and actually the cost of the care was really low. I did 2 home visits, one when they first got home and then a little later on to do more care planning. And he died May 13th, 2019 at home. I'm just about done, but I wanted to reflect on parents' comments. Mom and Dad said, having 24/7 support from Canuck Place gave us confidence to do this at home. And I've always said that we could not have this home program without our 24-hour access to expert nurses, physicians, and counselors. Parents said communication among the team was excellent, ensuring everyone was up to date, so we did not have to repeat conversations, and that was so important to them. At home, our son could have a friend sit in bed beside him and watch a movie, which was very important to him. We feel that our son was an exceptionally stoic and strong young man, and we are not sure we could have done this at home if this wasn't for his extremely positive attitude. Cooper did really direct his parents about what he needed and wanted in his living and his dying, and I agree, he really exceptional young man. And caregivers, I was unprepared for all I would learn in this environment. This was from one of the team members who'd never worked in pediatric palliative care. I was humbled by the extra mile every member of the team went to support this family. Even though it was really challenging work, I learned some important life lessons. It was so important for them to be at home and to remain connected with friends and family that loved them so much. And on that end, I wanted to share the bench friends and families created for him. It's just located across their street. I actually walked there with Cooper when I was up, and he shared with me about how the whales come into that bay and loves to watch those. And so, you know, one of the not everyone can be at home to die. That's not necessarily the best thing or the way it can be done all times. But if it can in a supported way, it really does allow the family to remain connected with their community, and I think ultimately keep them connected through their bereavement with others that knew their child, which we know is very helpful. So thank you so much for listening, and I really appreciate all the support you give Canuck Place and our families to do this care. Thank you so much.
Excellent. Thank you, Camara. I am just going to, if you want to stop sharing your screen, we'll just, you can even come out of that. And thank you guys ever so much. And I will end with thank you for everybody who is listening to this redo. I think it's so powerful. Thank you, Camara. It's so funny. The first time through, I don't think I heard half of what you said, and I've read all the slides about 5 times. So it's just so powerful. And I think it's so amazing when you can share the story through one person's life. It really dives into how we can provide really great care. So thank you, and I hope your day goes really well. And I'll let you know what we do next.
Great. Thank you so much.